Hi guys, welcome to this brainstorming session. Paper 2 might have appeared a bit daunting to you guys, but then I think you guys are true warriors and you would have gotten into the groove and would have solved those questions properly. And let's not waste some time. We'll focus at the job at hand, that is to discuss all those important questions. I think my audio and the visual looks perfectly fine, and very good evening to everybody who has joined in. Just give me a quick thumbs up with respect to the audio and the visual part, and I think then we can get started. Everything is fine at my end, Dr. Gautam, Manish, Javed, Dr. Vishal. So let's rock the scene. The first question that I'm going to discuss before you spoke about, and do let me know regarding the wordings whether they are perfectly fine. Though we did a lot of backhand work at this, so that we could get to the accurate options. But still, if you can comment regarding the age group of the patient, or if there's some words that are missing, that would be great. So we had this ECG, and I mean this is a favorite wo inferior wall MI या anterior wall MI पूछता है. So he said, or he spoke about a patient with chest pain, and then he described ECG findings. And howsoever casual we are, I think it's very hard to miss that peculiar ST segment elevation, which is present in lead number V2, V3, and V4, which ensure the fact that the answer for this would become anterior wall myocardial infarction. I am also looking at lead number 2 and 3. If I just zoom into the image for 2 and 3, I can say there are a bit of reciprocal changes that would be present. But primarily the changes that I am seeing in this patient would be referred as Pardy sign, as they technically call it. That's ST elevation with a convexity in upward direction. So I am very sure. Okay. Yes, V1 to V4 and ST elevation present. So the ECG that I have doesn't have it in V1, but cool. In case you got it between V1 to V4, that was perfectly fine, Dr. Novigush. So I think we are sorted for this question. Anything related to the age group of the patient, if it was given, please comment in the chat box. Anything related to clinical findings, it was given. Any biomarker report that was given, that would, I mean, we have already sorted out the area of the heart which is having an ischemia, but still, like, if you just want to add anything with respect to the clinical findings. Yeah, doc, that is what I've highlighted, the reciprocal changes, the arrows that I have done. So I think that I have already, I mean, we did take care of getting an image as close to the actual exam as possible. So though this one does not have an ST elevation very characteristic in V1, but the remaining changes, the reciprocal changes are very much present. Okay, fine. So if the image is very close and the findings are fine, we can do it. And Doctor, as far as the detailed discussion of everything is concerned, it would be available in the app subsequently. At the moment, our objective is to mainly get as close as images and as close as possible to the options as was there. Okay, the blood pressure of the patient was given in this particular case. So blood pressure was something, any diastolic value, doctor, that you would like to give? Systolic was 150. And think about the diastolic, Tarun, for this particular case. Because there was a separate question, day 5 a patient came and he died. So I hope we are not talking about that. Any diastolic blood pressure values for this one? Fine, this does not change the output in the question anyway, so I'll just add the point there. The patient was a hypertensive guy and he ended up with a myocardial infarction. For the second question, it was an ABG report, and I got two varying answers there, though. Okay, heart rate also described in the case. The heart rate was on the higher side. So got it, doc. I mean, there's gonna be sympathomimetic stimulation due to the chest pain component, and that can explain the manifestations of tachycardia and hypertension in this guy. So, okay, let's move on to the next one. Yep. In this particular report, the feedback that I got was that pH, PCO2, and the bicarbonate values all were going in same direction. It was a big report. Even electrolytes were given. The values of electrolyte may not be matching because obviously we cannot reach to that exact value and people would not be remembering. But the point is, considering the fact that there is gonna be like all arrows going in the same direction, pH, PCO2, and bicarbonate, this would be metabolic acidosis. Yes, great. And thanks, Pratik, for the kind compliment. As far as the ABG report is concerned, we always use that mnemonic ROM, or if you don't want to get into mnemonic, the bottom line is like pH and PCO2 going in same direction is going to be metabolic, and if they go in opposite, it's going to be a respiratory problem. So I think no disparities in this one also. pH was very low, bicarbonate, PCO was also low. So great. I think we are very close to those values. We may not be able to reach to that exact value, but yes, as long as the gist of the question and the concept is fine, we are good to go. The answer to this one is metabolic acidosis. Next was a long stem question, but then again a hot favorite of the examiner body, a lady with generalized muscle weakness, ptosis, and double vision, and that worsens with activity. I think this phrase was given that the manifestations in the patient will worsen with activity and will improve on rest. Even she's saying that when she's trying to drink water or she's eating in the evening, the symptoms are worsening. So that's very classical for myasthenia gravis. And the question also assisted by helping you regarding tensilon test per se. The question said tensilon test shows an improvement in muscle power. So it is a two-step question. I mean, you just have to work out the diagnosis of myasthenia gravis and then come on to the correct answer. That would be either a repetitive nerve stimulation or a single fiber electromyography. And the question did not, okay, most sensitive. Okay, best to confirm, that's okay. I mean, I'll say most sensitive one. And I think in the stem of the question itself, he had mentioned regarding tensilon test being done in this particular case. So if we look at the options, this is the most specific antibody. In case you listen to the workup of myasthenia gravis from rapid revision, I mean, the first statement is anti-acetylcholine receptor antibody is a specific test, and then for diagnostics, it's always electrophysiological studies that need to be done, and it's either a repetitive nerve stimulation and नहीं 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 ओके ओके सो देर इज नो ऑप्शन अबाउट एंटीबॉडी तो मुझे बता दो फिर ऑप्शंस बता देना लाइक आई थिंक everybody is clear about the fact that single fiber electromyography was in the options, and I got B as comment right away, so I just wanted to confirm. Even if there's no antibody, let me know. Okay, asked for diagnosis. Fine, doctor, that's okay. I mean, the gist of the question still remains the same. He says, how would you be helping in diagnosis of this question? There are two separate questions. एक myasthenia gravis अलग से था, ये वाला वो वाला question नहीं है. That is coming later. You know, there are two questions on myasthenia gravis. So as long as electromyography, that is what I was asking. Shivam has come up with a good answer. So if you can just follow in the comment with respect to whether electromyography was in the options or not. Why not nerve conduction velocity? Because because this is not a disease of the nerves, right? It's a disease of the neuromuscular junction. So that is why we'll be going ahead with this. Okay. Yes. There are two questions. The second one is the one where the antibody details were given. Fine, fine. So I think the correct answer for this one is electromyography. It is not antibody titer anyway. And in case antibody was not given, you can just suggest an alternative one. Yeah. Yeah, nerve conduction velocity I've written, doctor, I've written. It's not a repetitive nerve conduction velocity. Na? Repetitive nerve stimulation is different from the plain nerve conduction velocity. Okay. Okay, thank you, doctor, for the kind compliments. I think we are close to the gist of the question. The only thing is we are debating whether option, though we know the answer, we are debating whether option number C was present or not. चलो ठीक है fine. Best पूछा, most sensitive पूछा, they basically mean the same only, and the concept is कि antibody specific होती है. Okay, that's an interesting one. We'll come to that question also, so give me a while. रवि, अलग एग्जाम में अलग ऑप्शन इसलिए थे क्योंकि जो दो क्वेश्चन है myasthenia gravis के आप दूसरे के साथ में मिक्स कर रहे हो. दैट इज द रीजन कि आपको लग रहा है कि ये दूसरा ऑप्शन वाला क्वेश्चन है, राइट? सो ध्यान से पढ़ो. Okay. The next one talks about, I think there were two questions on pulses. Just let me know whether there was a question with respect to pulses bisvariance. Very first thing, the key word in the question present or not. Pulses bisvariance. No, I know you know the answer to the question. My only question is, was pulses bisvariance present in a question? Because we are having a young guy with chest pain, so obviously we'll think about structural heart disease. But if as long as pulses bisvariance word is present, then it will make it easier for us. Okay. Yeah, we are coming to that question on pericardial effusion subsequently. Okay. There was no question like this. Okay, fine. Got it. As long as pulses bisvariance word is not there, then there would be नायन पता, दैट्स ओके. अगर आपके क्वेश्चन में एरोज ऑपर्ड जा रहे थे तो रेस्पिरेटरी हो जाएगा. इफ दे गो द सेम डायरेक्शन देन वी विल से इट इज मेटाबॉलिक एसिडोसिस. Okay, fine. So not a problem. I'll not take this one into consideration, and we move on to the subsequent one. इसका भी मुझे बता देना पहले तो कि था कि नहीं था, फिर मैं आगे डिस्क्रिप्शन में देता हूँ. Patient is developed paralysis in both legs and then in the upper limbs. So he is probably talking about an ascending paralysis. Ascending paralysis. You mean pulsus variance? चलो ठीक है, अगर पल्सस बिस्फेरियंस था तो हमारा आंसर हाइपरट्रोफिक कार्डियोमायोपैथी है. अगर अगर पल्सस बिस्फेरियंस नहीं था, आई थिंक देयर वर टू क्वेश्चंस, एक इरेगुलर पल्स का था, एक बिस्फेरियंस का था. एंड आई थिंक ए एंड बी जो निमोनिक होता है उसके दोनों शुरुआत के जो दो अल्फाबेट्स हैं, दे आर व्हाट दे हैव कवर्ड. So yes, now we will focus on the subsequent question, which will talk about paralysis in both legs and then in the upper limbs. So he is talking about ascending paralysis in a patient, which is probably a patient with Guillain-Barré syndrome. Now is shown a recovery, and the current features of the patient are paralysis of the lower trunk and both the legs only. Hanji, hanji, hanji. Yes, yes, yes. This question is for a child. Okay. This question is for a child, not for adult. Okay, so let me know finally that, okay, there is extremities. Got it, got it, got it. If we say child and you said that there is gonna be नहीं नहीं, वो अलग क्वेश्चन है, कुछ स्मॉल ब्रीदिंग वाला अभी आएंगे. यहाँ पे चाइल्ड था, चाइल्ड को पैरालिसिस था, तो कोई कंफ्यूजन नहीं है, मैं सॉल्व कर देता हूँ. और जो पैरालिसिस है वो पैरालिसिस इज मोर इन द लेग्स एज कम्पेयर टू द आर्म्स. ही इज बेसिकली टॉकिंग अबाउट अ चाइल्ड विद सेरिब्रल पाल्सी. सेरिब्रल पाल्सी जो होती है जिसमें स्पास्टिक मैनिफेस्टेशंस होती हैं, इफ द पैरालिसिस इज मोर इन द लेग्स एज कम्पेयर टू द आर्म्स. Yes, I understand. I got the question. If it is an adult, so I'm totally saying not a problem. If it is an adult, that I'll obviously talk about paraplegia because it's a paralysis of lower legs as well as the trunk. But if a question is on a child with paralysis more in the legs as compared to the arms, then the answer for the question will turn out to be diplegia. So there are two separate aspects. Normally, like in Guillain-Barré syndrome, we have involvement of the spine, so we have paraplegia developing. But if it's a child, and yeah, it's not a quadriplegia because it is mentioning legs more than the arms. So I got that feedback also. I think I could immediately pick up what the question was trying to say. So the correct answer to the reframed question that I have currently mentioned before you would be presence of diplegia. Even if it is not a child, if the paralysis is more in legs as compared to the arms, the answer would be given as diplegia and would not be given as quadriplegia. So that's the basic difference. Yeah, doctor. R said a very pertinent question. What is the difference between paraplegia and diplegia? So paraplegia का मतलब होता है that the paralysis will involve the lower trunk as well as it will involve only the lower limbs in a patient and will not be involving the upper limbs. Paraplegia का मतलब होता है कि सिर्फ legs का paralysis और lower trunk का paralysis होता है. And diplegia is a condition where you have diplegia. Hemiplegia का double कर दो. Diplegia कैसे समझना होता है? Hemiplegia का 2x कर दो. So that's gonna work out to diplegia where the involvement is more in the legs as compared to the arms. So I hope that sorts out the question. If it is gonna say paralysis of lower legs and the trunks, we work out to paraplegia. But I get the gist of the question. I think this was a hardcore pediatrics question related to spastic diplegia. Okay. Quadriplegia is paralysis of arms and legs, but would be of equal strength. That would be agreed. So I think I explained that R to you. Okay. Moving to the next one, he said 60-year-old patient presents with chest pain of 5 hours duration and he collapses in the emergency room. I hope it was 5 hours only. And let me know in the comment box whether it was 5 hours. And then he collapses in the emergency room and goes into a cardiorespiratory arrest. ओके अर्लीस्ट नहीं होगा, हटा देते, अर्लीस्ट विल नहीं, फिर भी आंसर तो खैर वर्कआउट हमने करना ही ना. विच ऑफ द फॉलोइंग विल बी यूज्ड फॉर डायग्नोसिस ऑफ दिस पेशेंट. ओके हाँ जी हाँ जी, मायोग्लोबिन डाल भी दो फिर भी वो आंसर नहीं होता ना, क्योंकि थेराप्यूटिक नहीं है ना यार. मायोग्लोबिन इज नॉट गोना बी डायग्नोस्टिक ना. सो व्हाट इज I think there's a delay in the chat, so somebody mentioned the previous question also. It doesn't matter, doctor. He is mainly asking about the diagnosis of the patient. No, myoglobin is never used for diagnosis of this patient. Even if he says earliest, it doesn't say earliest. अगर आप क्वेश्चंस देखते हो तो LDH is gonna be last to used. Albumin per se alone is never, we have heart fatty acid binding protein ischemia, modified albumin, that's all textbook data. So you don't need to bother about it. बच गया CPK-MB. CPK-MB takes about 4 to 6 hours to rise, whereas troponin I can be elevated as early as about 3 hours. So finally, the main diagnosis is made on the basis of troponins only. I think it is a straightforward question that has been blown out of proportion without a reason. I mean, how do you diagnose myocardial infarction in a hospital is what he's trying to say, and we use troponin for diagnosis in this particular case. First rises is not ischemia modified albumin. First to rise is myoglobin only. It is myoglobin. We'll go by textbook data, not by what if he says what is earliest to rise and myoglobin is in the option, I don't have a dispute with that. But if the way the options are, then it is troponin I. Okay. Okay, Ji, fine. So I think it's a simple question on diagnostics per se for myocardial infarction. Next, we're going to talk about pneumomediastinum because we talk about pneumothorax. So he thought that, okay, still, doctor, I mean, if it is ischemia modified albumin, what we clinically do for diagnosis of myocardial infarction is troponins basically. Okay, pneumomediastinum would be useful for pneumomediastinum is going to be found in which of the following situations. So everything else is a dummy. I think everybody could pick up manifestations of Boerhaave syndrome as well. Okay, fine. So this is an easy one, spot on. Nobody had any issues with this one-liner. Okay, esophageal perforation. So Dr. Boerhaave syndrome means the same thing only. I mean, whether you call it Boerhaave or whether you call it esophageal perforation, both imply the same. But I'll point taken. I'll incorporate that in the final script. Yeah, you can let me know the options if you can comment on that one, right? Esophageal perforation, anything apart from this. The concept is Boerhaave causes a esophageal perforation. So there might have been more than one question on the same only. That doesn't change the final output. ठीक है जी, ठीक है. Esophageal में esophagus में डैमेज है यार तो pneumomediastinum होगा. ओके. अगले में मुझे बताना है आपने कि was it a lady in the third trimester or was it an adult man with hypertensive encephalopathy? Basically, yeah, I got it. Dr. Field, I got it. Like, I think one, the surgeon is already handled, so I did not touch it. The esophageal perforation, what I thought I'll just touch upon the pneumomediastinum man. In this particular question, was it, okay, patient drank too much alcohol and too much food. Okay, got it. Lot of food taken by a patient, lot of alcohol taken by a patient. Got it. And then he would have puked probably, and that is when the esophagus would have simply popped off. Okay, lady था but trimester नहीं था. Okay, lady था but trimester नहीं था. Got it. It's okay. I mean, whether it is gonna be a lady or whether it's gonna be adult man, gender will not change. All the question is trying to say is it's gonna be presence of hypertensive encephalopathy, and in case there is gonna be a hypertensive encephalopathy, I need to. Yeah, even if person is not pregnant, doctor, if it is hypertensive encephalopathy, I need to go on a war footing and I need to use drugs. If I'm having nicardipine in options, which I want to know, then this would be the first line answer. If it is not, then it is gonna be, that's okay, man. Whether it's a lady or adult man, that is not gonna change. If she's not pregnant, that means the question is not on eclampsia. Now, that's the bottom line. The question is not on eclampsia. So there was NTG that is present. Nitroglycerin is given if there is a development of left ventricular failure. The diagnosis of this patient is hypertensive. यही तो बता रहा हूँ यार. अगर ये होता ना hypertensive crisis with left ventricular failure, then the answer is IV nitroglycerin. Listen to the hypertension discussion. Whenever we have spike of blood pressure and there's a left ventricle failure, we give IV nitroglycerin. If it is a hypertensive encephalopathy, then we will be using labetalol in the patient. And no, there was no, I don't think so. This question had pheochromocytoma as a presentation. It was an adult person with high blood pressure ending up with a hypertensive encephalopathy. So standard answer would be nicardipine or it would be labetalol that would be given for this question. Okay, tremors and palpitation described in the question. Got it. Maybe there was no mention of the word pheochromocytoma, but he was trying to imply that this is a pheochromocytoma patient who's ending up with a hypertensive crisis, and I will be using labetalol in this patient. Yeah, the drug of choice or the best drug for management of this patient, the answer would remain uniform. Yeah, PhD symptoms. I got it. I got it. I mean, there was no pheochromocytoma word, but it was symptoms suggestive of pheochromocytoma, and then the chap was landing up with a very high blood pressure. Okay, and there was no left ventricular failure in a patient. निफेडपिन नहीं यूज करते हैं बिकॉज निफेडपिन कॉजेज अ सडन फॉल इन ब्लड प्रेशर ना, तो सबलिंगुअल जो निफेडपिन पहले देते थे उसको क्यों नहीं यूज करते, बिकॉज इट कॉजेज अ वेरी अनप्रिडिक्टेबल फॉल इन ब्लड प्रेशर. यू नीड टू एक्चुअली use a drug which you can predict in 1 minute how much blood pressure will fall, in every 15 seconds how much blood pressure will fall. I need a predictable response, right? I don't need to have an unpredictable response, which is why we will not be using a sublingual nifedipine for this particular case. So I think I got the gist of the question. Pheochromocytoma chap, hypertension, and we are asked to control the blood pressure of this chap. Next is about lumbar puncture, and I think it was done in sitting position. ये थोड़ा comment कर देना, lumbar puncture was done in sitting position or lumbar puncture was done in lying down position. And now the person is having a very severe headache. So the question is regarding management of a post lumbar puncture headache. Okay. Okay, RD, I just took your input there. Male having hypertension, not lady, that's okay. Labetalol, nitroglycerin, nifedipine, and hydralazine. Got it. Doc, I'll still go with, I think, AHBI, something, some name came. So I think I've just taken a note of that. NTG is when you have a heart failure present. Got it, got it. Even if it is that intravenous one, doctor, I mentioned. Just mentioned history of lumbar puncture. Okay, post lumbar puncture headache is what is describing in this particular case, and he's saying कि क्या नहीं करेंगे. So patient would be made to lie down in supine position. That is okay. Drug of choice for post lumbar puncture headache is caffeine, and yeah, post dural trauma is the one which is contributing to the manifestations in this question. And then we will use a low volume blood patch in this patient as well. So increase caffeine intake. Okay, okay. So I'll not make it IV. I will say कि hot chai या coffee दे दिया. Suggested watches, listen to post lumbar puncture headache complication, that is headache described, and the steps that have been enumerated in the management of this. This is actually a question which has been asked in previous times. There he just asked drug of choice for management, that is caffeine, and now we are trying to increase caffeine intake. And I've explained that कि भाई IV अगर available ना हो तो चाय कॉफी पिलाओ, उससे भी improvement हो जाएगी. So and give stool softeners in a patient. Only history of lumbar puncture. Yeah, ठीक है doctor, that's okay. I mean, the concept is, the question is on post lumbar puncture headache और हम क्या नहीं करेंगे. Okay, okay, fine, fine, fine. Yeah, ठीक है जी. ओके, नहीं नहीं, ब्लड पैच तो लगाते हैं ना यार. रिस्ट्रिक्टेड वाटर इनटेक क्यों करेंगे यार, पानी पिलाएंगे ना उसको, हाइड्रेशन तो मेंटेन करेंगे पेशेंट की. वाई टू गो फॉर रिस्ट्रिक्टेड फ्लूइड इनटेक. ओके, स्टूल सॉफ्टनर, आई एग्री टू दैट, दैट कुड बी वन ऑफ द ऑप्शंस प्रेजेंट. आई जस्ट ऐड दैट. आई मीन आई विल गिव स्टूल सॉफ्टनर, बिकॉज क्यों स्टूल सॉफ्टनर दूंगा, क्योंकि अगर इसको कॉन्स्टिपेशन होगी, बिकॉज ही विल बी लाइंग इन बेड, तो कॉन्स्टिपेशन होगी. व्हेन ही विल हैव कॉन्स्टिपेशन, व्हेन ही विल स्ट्रेन, एट द टाइम ऑफ स्ट्रेनिंग देयर विल बी मोर लीकेज ऑफ CSF एंड द हेडेक विल इंक्रीज. लाइक व्हेन आई हैव डिस्क्राइब्ड दिस, तो तब भी मैंने समझाया कि जब वो पेशेंट यूरिन पास करेगा, स्टूल पास करेगा, द हेड ऑफ दिस पर्सन ही विल से एज इफ इज एक्सप्लोडिंग. सो स्टूल सॉफ्टनर का लॉजिक क्या है? स्टूल सॉफ्टनर इज बेसिकली यू आर ट्राइंग टू न्यूट्रलाइज द कॉन्स्टिपेशन कंपोनेंट. द रीजन फॉर कॉन्स्टिपेशन इज बेड रिडन पेशेंट, एंड कॉन्स्टिपेशन में जब वो स्ट्रेन करेगा, देन इट्स गोना इंक्रीज द लीकेज ऑफ CSF फ्रॉम द रेंट और द टीयर इन द ड्यूरा मैटर, and that is why stool softener is something that I would like to do for this particular patient. So increase caffeine, but yeah, I think Dr. Audi, again, that I think it's in Russian, so I'll call you Audi. That's looking fine. I hope, doctor, you don't mind, because that's the alphabet that I'm able to read. But then it's gonna be restricted water intake is what I'll not do in this particular case. Okay, yeah, that doesn't change the perspective, doctor. Like if I'll just add that word up, that duration was given. Though I think that's very debatable, because patient would be having manifestations immediately, but still okay. कि भाई उसको हेडेक है, पोस्ट लंबर पंक्चर हेडेक, तो आप क्या करोगे या क्या नहीं करोगे, इज द जिस्ट ऑफ द क्वेश्चन. ओके जी, ओके, राइट. लेट्स मूव ऑन टू द नेक्स्ट वन. द इमेज पहले तो बता देना मुझे, वाज इट अ CT स्कैन और वाज इट एन एक्सरे? फर्स्ट इज प्लीज कमेंट whether it is no doctor, it is we have done a lot of groundwork. It's not like we are just coming randomly just like that in front of you. So it is what is not to be done. It is exclusion that has to be applied in this particular case. Okay, cool, cool. Nice place, doctor. You've been to a good country, a beautiful one which has been destroyed. Okay. Moving to the next one, it was an X-ray. Okay, fine, fine, fine. It was a chest X-ray. Got it. Next, let me know whether in the chest X-ray, what was the cardiothoracic ratio? Was the cardiothoracic ratio, I mean, the heart was bigger in size, heart was normal in size. हाँ X-ray में समझ गया. It was कुछ small breathing. Okay, okay. Fine, fine, fine. नहीं नहीं कुछ small sign नहीं वो they are saying कि ये कुछ small sign था ही नहीं क्वेश्चन में. So, interesting one. कुछ small breathing. Okay, okay. ठीक है, got it. CT ratio and the cardiothoracic ratio was increased in the question. Fine, 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 fine. So there would be changes in the pulse now. Got it, got it. Cardiothoracic ratio is increased in the patient. Yeah, we are talking about the CPR, that is 30:2. That is the standard ratio for two rescues. That is the next question that is coming up. But because the CT ratio is increased in the patient, it means that the question is on cardiac tamponade. And if it is going to be cardiac tamponade, then it is the pulse that would be hampered in this question. Now, let me know, okay, which of the following pulses alterance is not in the option. तो please comment कर देना यार, कोई ना कोई pulse तो होगी. या कुछ small breathing में समझ गए. Fine, fine, fine. Hi Nizam, good to hear from you and thanks for the kind comment. Okay, pulses bis variance इसमें. Okay. Yeah, I got it. I got it. I got it. There was history of tuberculosis and yeah. Okay, one option is इसमें था pulses bis variance. Got it. इसमें pulses bis variance था. Yes, yes. Keep the options coming. Pulses bis variance I've got. TB ka history was given in the case. That also I've taken up. Good one. Now there's a tuberculosis patient, pericardial effusion. It's increasing, increasing, increasing. It is contributing to a tamponade. Yes, I think Suma got it right. That is about changes with respect to. He did not talk about muffled heart sounds, but he was trying to indirectly talk about pulsus paradoxus, where there is gonna be a inspiratory fall of systolic blood pressure, and this inspiratory fall of systolic blood pressure would be more than 10 millimeters of mercury. I got it, Tarun. You got it spot on. And yeah, I got it. The second option is about small breathing, and we are narrowing down to the options very, very correctly. I mean, इसको बोलते हैं जज्बात बदल दिया. I thought it is constrictive pericarditis, but then it is not small sign, it is small breathing. And since it is cardiac tamponade, I mean, they are just playing with the mind. And is in this particular question, got it, that blood pressure of the patient is on the lower side. So that is what we are going to answer in this particular case. Hypotension would be a manifestation. The correct answer for this one is option number C. There's going to be hypotension, there's going to be pulsus paradoxus present, and the way probably he described that in the question was an inspiratory fall in systolic blood pressure, or maybe an absolute value of systolic blood pressure was given in this question. Yeah, Khan Samir summarized it. This inspiratory fall was given between 80 and 60 millimeter of mercury. So you can see now that is a fall more than 10 millimeter of mercury. I mean, the definition of the word pulsus paradoxus is inspiratory fall in systolic blood pressure of a value more than 12, actually technical values more than 12 millimeter of mercury. So yeah, we know you got it spot on. I think that is a good relevation for me as well, as far as this question, that we are not going to be talking regarding constrictive pericarditis. Okay, so we are sorted for this one, and I really appreciate your recall capabilities for this one, because the input that I got was totally different. And now we have another one where we are talking about CPR frequency for an adult. Just let me know बच्चा था कि adult था. Whether it is an adult, and reverse Barham effect is that shifting, no? Reverse Barham effect is only the septal deviation component. But you have a good point there, Nizam. Reverse Barham is basically gonna contribute to pulsus paradoxus. Okay, adult है तो फिर तो कोई दिक्कत ही नहीं है. मतलब whether it is a single rescuer or whether it is gonna be like you are two people, one with your medic, it could be medic, it could be okay, two rescuers लिख देता हूँ. It is two rescuers. I mean, a doctor and a nurse, or like two doctors available. So whichever be the situation, the point is, if it's gonna be two people, it's gonna be 30:2 as a ratio. Right. The answer for this one would be option number B. So I think we are sorted for this one. Next one is again right in the beginning part. Let me know regarding irregular pulse. Was it described in a question and there was alcohol? Okay, 30:1. I'll just put it up, doctor. This is, I think, 30:1. It's a moderate paper, doctor. There are a lot of twists. No, if he can put कुछ small sign and कुछ small breathing, तो फिर वो कुछ भी कर सकता है. Okay. नो क्वेश्चन नहीं समझा भाई मैं। अच्छा ये क्वेश्चन नहीं था, ओके फाइन, गॉट इट गॉट इट, नॉट नॉट प्रेजेंट, फाइन। चलो नेक्स्ट वन बताओ। पेशेंट केम विद द हिस्ट्री ऑफ रिकरेंट एपिसोड्स ऑफ हेमोचूरिया दैट reoccurs when he develops a URI, and then he mentions KFT of a patient, and he talks about C3 values as well. I don't want you to comment on the diagnosis. What I want is input from you guys with respect to the options per se. I mean the language and the framing of the question per se. Yes, guys. नहीं था। Okay, okay, okay. Fine, fine, fine. Not a problem. Mechanism of action of apixaban इस पे बता दो। apixaban था कि rivaroxaban था? हाँ, या। अरे भाई दो चार क्वेश्चन ही तो हैं यार जो उनसे सोर्सेस ठीक नहीं आए, बाकी तो आई थिंक दे आर डिसेंट वंस, राइट? ओके, मैकेनिज्म ऑफ एक्शन ऑफ apixaban, rivaroxaban, चलो ठीक है। ठीक है जी, फैक्टर 10 इनहिबिटर, ये तो फार्माकोलॉजिस्ट ने भी डिस्कस कर दिया होगा, सो वुड नॉट बी हैम। या दैट वुड बी बर्जर्स डिजीज। ओके, let's move on to the next one. This was a lady with obstructive lung disease and she's currently on salmeterol and tiotropium. इसका भी पहले तो यही बता देना। Question regarding Henox colon papura. Okay, that is interesting. That is interesting. I'll just put it up there. HSP, because he's talking about IgA nephropathy probably. Okay. Okay, so there's an obstructive lung disease patient. That is the first rule. And I mean, he mentioned obstructive lung disease. Then drugs, I think they're same, salmeterol, tiotropium, or was it like budesonide with the standard inhaled corticosteroids combination, LABA and LAMA combinations that were there? Okay, which will increase the lifespan of a patient. Okay, which will increase best for this patient or increase the lifespan. Got it. Yes. Increasing the lifespan of this patient. Okay. समझ गए, ऑप्शंस अलग हो जाएंगे। आई थिंक वन ऑप्शन वाज रिगार्डिंग ऑक्सीजन एडमिनिस्ट्रेशन, वन वाज रिगार्डिंग न्यूमोकोकल वैक्सीन। आई गॉट इट। न्यूमोकोकल वैक्सीन। हाँ, अभी थोड़ा बेटर हो गया, दो ऑप्शंस क्योंकि बेटर हो गए। वन इज लो फ्लो ऑक्सीजन, दैट इज LTOT, एंड सेकंड इज गोना बी न्यूमोकोकल वैक्सीन। बाकी ऑप्शंस देख लो एंड देन आई कम टू द आंसर। द मेन वे टू इंक्रीज लाइफ स्पैन इन दिस पेशेंट्स, budesonide and okay fine, he is on LABA and LAMA. Okay, got it. Okay, all three of them are present. I'll just jot it down, doctor. That's a good input. He's on three drugs, LAMA, LABA, and inhaled corticosteroids. And then what he's asking me is that for this patient, how would I increase the lifespan of this patient? Positive pressure ventilation. Yeah, got it. Positive pressure ventilation. Yes, I think now we are making a much more refined format of this question. It is going to be positive pressure ventilation. It's a low flow oxygen. It's going to be pneumococcal vaccine. The main treatment is LTOT, or long term oxygen therapy. Now that is going to increase the survival capability of this person. Okay. Hand mouth in coordination given in the question. Okay, because of the hypoxia component, doctor. Yeah. Okay, Medico 2020. I mean, different people. Some people said there was no question like that, but I think PSGN is a question or a topic that they would have asked somehow, but people were vocal about the fact that there was no such question, so I did not go through it. Okay, fine. ICS in the options. Okay, I think lab inhaled corticosteroid तो मिल रहा है यार उसको, तो आंसर इज LTOT। तो दीप साहा दैट इज ओके। ऑप्शन में, अच्छा ऑप्शन में था, ठीक है, समझ गया, नेबुलाइजेशन विद, गॉट इट। तो दैट इज ही सेइंग कि यू विल चेंज द अप्रोच फॉर दिस पेशेंट। समझ गया। इट इज लामा लाबा का नेबुलाइजेशन, गॉट इट। तो नेबुलाइजेशन से फर्क नहीं पड़ने वाला है। व्हाट इज गोना हैपन इज, और व्हाट्स गोना इंक्रीज द लाइफ स्पैन इज ऑक्सीजन ओनली। सो आई स्टिक टू माय आंसर, दैट इज LTOT, दैट वुड बी रिक्वायर्ड। ओके, ठीक है, फाइन। Moving to the next one, it says 18-year-old girl. Yeah, COPD with core pulmonary. So I think there were two questions on COPD also. They love that topic. Okay. Yeah, Dr. Rajavat, I got your point. I got your point. That the question is on COPD and increasing the lifespan and change of device also. Okay. I think this is again the second question on myasthenia gravis. Let me know regarding the options for this one also. ठीक है, old monk, I got your point. Henox-Colin purpura for immunoglobulin A could be present. हाँ, ये दैट इज द पॉइंट कि पेशेंट को हैंड और ब्रेथ का इनकोऑर्डिनेशन है, दैट मींस ही इज नॉट बीइंग एबल टू यूज द डिवाइस प्रॉपर्ली. सो आई गेट अ पॉइंट. There are two questions on COPD. One question is the one that we have discussed, and the second problem is that there is a hand device in coordination, and then he's saying कि क्या करेंगे, तो वहां पे we will have to improve the technique in the patient. Got it. Okay, got the inputs for the second one also. This will incorporate Lambert-Eaton in the options. Lambert-Eaton would be found in old age, would be related to a malignancy, so is unlikely as an answer. Okay, lid drooping that increases. Fine, fine. So I think this has no issues. Gaspach syndrome, I pick it up, doctor. Gaspach syndrome is secondary polycythemia. I think we'll add that to the pathology section, but anyway, right. Gaspach would be relative polycythemia. एंड डिफिकल्टी इन चूइंग, आई थिंक वो फिर पीछे वाला अभी आपने शायद ज्वाइन किया है चैट, तो देयर वाज अ टू डिफरेंट क्वेश्चंस ऑन माइस्ट्रा ग्रेविस व्हिच इज व्हाई वन ऑफ देम वाज हैविंग दैट डिफिकल्टी इन चूइंग वाला कंपोनेंट. ओके. Yeah, the question on NTG usage device would mainly focus on the fact, I think it was pharma, you just need a gap of about 8 to 12 hours to prevent a tolerance. For nitroglycerin, we always go for erratic dosing. Like we want that person should not become a tachyphylaxis nahi hona chahiye. So it is like 6 to 12 hours ka gap for that. Okay. Yeah, Dr. Pandit, I think you joined at the moment. So that question on electromyography, we have already sorted out. Moving to the next one, gluten-free rice is what I got in one liner. Somebody said gluten-free rice and malabsorption syndrome. Okay, fine, fine, got it. Gluten-free rice was not there. Next, बता देना best for long-term control of diabetes mellitus. Yeah, difficulty chewing. I got it. I got it, doctor. That difficulty in chewing component. I'll add that word there. I mean, the lid drooping and difficulty in chewing component. But considering it's a girl and it's gonna be relatively younger, so that will make it easier for us. Fine. I think this would be glycosylated hemoglobin. Yeah, long-term monitoring would always be glycosylated hemoglobin only. There was a question on celiac disease. There was a question on celiac disease, and I think that is where gluten-free rice would be used per se. Got it, Dr. Stoner. I got your question. Answer would be 8 to 12 hours. हाँ तो language बता दो ना. Two questions about celiac disease. I know about that. I know about that. Right. अरे वो अलग क्वेश्चन है यार, डर्माटाइटिस herpetiformis वाला celiac sprue वाला, that I have already taken care of. That is like already discussed in pathology. Okay, let's move on to the next one. I think it was long-term control only. Best for long-term control. That is how we will be able to identify this, no? Okay. हाँ डॉक्टर समीर, आप कमेंट कर दो. I'm just waiting for your quick comment. कंट्रोल नहीं पूछा था तो फिर पूछा गया था. मतलब डायबिटीज मेलाइटस के लिए कुछ तो पूछा होगा ना. लॉन्ग टर्म कंट्रोल, शॉर्ट टर्म कंट्रोल, सिवियरिटी ऑफ डायबिटीज, समथिंग हैज टू बी देयर, राइट? Okay, blood sugar, urine sugar तो दिया हुआ है यार, sugar तो दिया हुआ है. I'll add blood sugar from the options for this one. Okay, fine. Moving to the next one. We are having 20, this patient is having weight loss, and then there is information with respect to intracellular organisms in the macrophages. Okay, check karna purana diabetes. So it would still be the same, man. It's not gonna change. Whether it's gonna be diabetes, whether it's gonna be severity of diabetes, it basically means the same. Okay, let me know for this one. Patient having weight loss with loose motions, and Boyle's biopsy Staph aureus will take care of that. Okay, and biopsy shows intracellular organisms. Okay, fine, got it, man, got it. Okay. Next is which is not correct about carcinoid tumor. या डायग्नोस्टिक टेस्ट फॉर डायबिटीज लॉन्ग टर्म वर्ड फिर आ गया तो लॉन्ग टर्म होगा तो HbA1c हो जाएगा. That would be Tropharma vipili, doctor. I think there was a question on Tropharma vipili. Maybe the framing of the question may not be very apt for bulky foul smelling stools, but then there was a question on Whipple's disease per se. Answer is HbA1c, old monk. Okay, which is not correct. Yeah. I got it. For that Audi wala jo hai comment, I could pick that up. Yeah. हाँ जी, इसमें बता देना कि whether it is not correct or whether it is correct about carcinoid tumor, and then we can go ahead. Okay. And option number C में चलो मैं not हटा देता हूँ फिर. Let's focus on the options here. ओके फाइन, विच इज द करेक्ट वन. सो यूरिनरी HIAA लेवल्स के बारे में क्या मेंशन था, वेदर HIAA लेवल्स. गाइस ऑप्शंस आपने मुझे बताने हैं ना. इट्स नॉट दैट आई विल नो द ऑप्शंस, यू गाइस हैव टू कमेंट रिगार्डिंग देम. ओके, 5 HIAA का लेवल नॉर्मल दे रखा है. दैट इज व्हाट आई एम ट्राइंग टू से कि F5 HIAA इज अ टेस्ट दैट्स यूज्ड फॉर डायग्नोसिस. लेकिन अगर उसका लेवल नॉर्मल दे रखा है तो यार वो तो डायग्नोसिस नहीं हो सकता ना. It is increased. Okay, elevated 5. Fine, got it. So as long as it is gonna be elevated 5 HIAA, that is gonna be the main test for diagnosis, and the word not is not there. Got it. So you say which is correct about diagnosis of carcinoid tumor, that is urinary 5 HIAA levels being elevated. Diagnosis का मेन तरीका पूछा था. तो अर्जेंटा फिनोमा में कार्सिनोइड मतलब सेरोटोनिन का एक्सेस है ना. तो सेरोटोनिन का जो ब्रेकडाउन होगा, हिस्टामिन का ब्रेकडाउन होगा, तो यूरिनरी 5 HIA के जो लेवल्स होंगे वो इंक्रीज हो जाएंगे. ठीक है, गॉट इट, सॉर्ट हो गया. Next one has been discussed by pathologists. Just let me know if the image was there like this. I actually has cytomegalovirus के लिए ना images भी एक ही दो है इंटरनेट पे, तो उन्होंने कुछ वो उठाई भी होंगी, तो I think they would have been standard images only. And let me know whether the patient underwent a kidney transplantation, whether the question, your diagnosis for carcinoid is 5 HIAA. That is what I've explained. Yeah, so cytomegalovirus, but a different one. ठीक है, got it. Yeah, गैसबॉक इज रिलेटिव पॉलीसाइथीमिया. रिलेटिव जैसे डेंगू हेमरेजिक फीवर में होता है, डायूरेटिक्स की वजह से होता है ना, दैट इज कॉल्ड एज गिसबर्ग सिंड्रोम. हाँ, दो आंखें, अच्छा ठीक है, तो दो आंख मैं आपको बता देता हूँ ना कि साइटोप्लाज्म इसमें एक दिख रही है, एक साइटोप्लाज्म में प्रेजेंट है ना, तो दो आंखें थी, मैं समझ गया आउलाई अपीयरेंस का. ठीक है. HIV पॉजिटिव पेशेंट, मुझे जो हिस्ट्री मिली उसमें था कि बर्न्स जैसा लग रहा था. अब वो मुझे आप बता देना कि वेदर इट वाज प्रेजेंस ऑफ वेसाइकल्स ऑन द जेनाइटल्स और वाज इट बर्न. बर्न के जैसे रेड रेड लीजन्स प्रेजेंट थे. कापोसी सार्कोमा में गाइस जो कट ऑफ रहेगा वो 200 का रहेगा. KS का जो CD4 काउंट का पूछा था, दैट वुड बी 200. ओके. First let me know, was it vesicles on the genitals or was it like ulcers on the genitals on the patient, something like a burn per se. So what I have shown is something like a burn, and that would make the diagnosis of this patient No, RBC mass would be increased, doctor, because there's a dehydration component. I'll comment on this gas box. Just give me about 3-4 minutes, and I'll comment on gas box syndrome subsequently. So if there's gonna be अरे भाई एग्जैक्ट इमेज तो कहाँ से लाऊंगा यार मैं. द पॉइंट इज, ऑल आई एम आस्किंग इज कि वेसिकल था या अल्सर था. तो व्हाट आई एम गेटिंग एज एन आंसर इज अल्सर. अगर अल्सर प्रेजेंट है तो हमारा जो आंसर रहेगा दैट वुड बी गिवन एज शैंक्रोइड. और अगर ये छोटे छोटे ब्लिस्टर्स होते तो देन वी विल से एज हर्पीस पर से. टॉक्सोप्लाज्मा का काउंट इज गोना बी 100. कापोसिस सार्कोमा इज गोना बी 200. एंड देन किसी ने गैसबॉक का पूछा. गैसबॉक क्यों होता है, तो उसका मैं रीजन लिख रहा हूँ यहाँ पे. गैसबॉक सिंड्रोम का रीजन होता है डायूरेटिक्स. जब किसी को डायूरेटिक देंगे तो बॉडी से पानी का लॉस हो जाएगा. अगर पानी का लॉस होगा तो जो आरबीसी काउंट होता है वो इंक्रीज हो जाता है. उसको बोलते हैं रिलेटिव पॉलीसाइथीमिया. दैट इज द टेक्निकल टर्म फॉर गैसबॉक सिंड्रोम. 8 to 12 hours for nitroglycerin travel, doctor. Yes, VS official, that is perfectly fine. As far as ulcer is concerned, it's gonna be chancroid. Okay, moving to the next one. He says what is correct with respect to the current image, and we can pick up gas under the diaphragm. And if it is gas under the diaphragm, नहीं 500 नहीं होगा. It is 150 to 200 का value. It is gas under the diaphragm. हाँ जी, less than 200. यार आंसर नहीं बोलो ना, मुझे बस ये बता दो कि इसमें कोई हिस्ट्री वगैरह दे रखी थी क्या. मतलब इट वाज एनीथिंग रिलेटेड टू पर्सन हैविंग सिम्टम्स ऑफ गैस्ट्राइटिस, पेप्टिक अल्सर डिजीज, और वाज इट अ वन लाइनर. Yep. No, doc. We'll put it as Abhishek as 200. Toxoplasma gondii is not 200, man. Toxoplasma cerebral toxoplasmosis 100. The value for cerebral toxoplasmosis is CD4 count less than 100. This would be hollow viscous perforation, guys. Kaposi would be 200, and if it is cerebral toxoplasmosis, that would be less than 100. Retrosternal back pain. Okay. इस पेशेंट में रेट्रोस्टर्नल बैक पेन थोड़ा सा अनलाइकली है. Okay, it was not a one-liner. The patient had a retrosternal pain. Okay, fine. ठीक है, बैक तो नहीं बोलेंगे. Retrosternal pain described in a patient. But he's giving us a history, and that history is suggestive of some kind of a gastritis component or a peptic ulcer disease, and then he's deteriorating and he's ending up with development of a perforation peritonitis. So I think we can figure that out. That would be pneumoperitoneum. That is a hollow viscous perforation. चलो ठीक है, I get the point. It may not have been retrosternal pain. There was a history given for peptic ulcer disease का suggestion, and then there is a hollow perforation. नेक्स्ट इसमें मुझे आपने काउंट्स बताने हैं. वील गो स्टेप बाय स्टेप. फर्स्ट ऑफ ऑल यू हैव टू टेल मी फॉर दिस क्वेश्चन दैट देयर वुड बी एनी लाइक history of fever, headache, and vomiting present in the case, because this question is basically on meningitis. We are trying to do a reverse, and in this reverse what we are trying to work out is whether there is gonna be viral or a bacterial or a pyogenic meningitis scenario. Okay, it was a cloudy CSF, that is okay. Polymorphs mentioned, the sugar was 35. So sugar is low, polymorphs are there, so going in favor of bacterial. Right. Protein का value कुछ बोलेंगे? It was a PMN predominance present, not a lymphocytic predominance. History of fever of 20 days. Okay. Guys, can you just comment regarding this history of 20 days, please? Protein was 200. Okay, interesting. Protein is 200. Can you comment regarding history of 20 days of fever? Seizures and convulsions also given. Okay. Got it. मैं सिर्फ अब नहीं, इट्स नॉट इजी यार. इट्स नॉट इजी कि ग्लूकोज लेस है. वो तो हमने वायरल को सिर्फ रूल आउट किया है. सिर्फ 2 ही ऑप्शन रूल आउट हुए हैं. अभी भी बैक्टीरियल और टीबी में मुझे जानना है कि क्वेश्चंस में न्यूट्रोफिल्स थे या लिम्फोसाइट्स थे, क्योंकि अब एक कमेंट आया कि देयर वाज प्रेजेंस ऑफ लिम्फोसाइट्स प्रेजेंट. Okay, different question था for fever for 20 days. 8% lymphocytes, 85% polynuclear cells. Good. So now I'm getting much more better data now. ठीक है, got it, got it. Leukocyte तो होंगे ही होंगे, but predominantly तो neutrophils present है ना. Okay, okay, fine, right. Polymorphonuclear cells था, ठीक है. नहीं नहीं, मैं समझ गया यार, दो सवाल थे, अभी हम इसकी बात कर रहे हैं ना. अभी वाले क्वेश्चन में मुझे बस ये बताना है न्यूट्रोफिल प्रीडोमिनेंस थी या नहीं थी. दैट इज ऑल आई एम आस्किंग. अगर न्यूट्रोफिल प्रीडोमिनेंस है तो विल मेक इट एज बैक्टीरियल मेनिंजाइटिस बिकॉज एवरीथिंग एल्स इज गोइंग इन फेवर ऑफ दैट. द ओनली पॉइंट इज दैट द हिस्ट्रीज आर वेरी लॉन्ग, सो दैट वील हैव टू लुक इनटू. एंड देयर वर टू डिफरेंट क्वेश्चंस विद टू डिफरेंट perspectives present. Okay, polymorphonuclear cells will make it first differential diagnosis with respect to a history which is going to be shorter, would be going as bacterial meningitis, considering the fact that there is going to be presence of no guys, it is not like that. It is that we have to work out a data retrospective analysis करना होता है. ऐसे escapade attitude तो सबके लिए होता है ना कि भाई रहने दो ना, काय को टेंशन बढ़ाना है. But not like that man. You need to learn to handle things. Okay, इसको बोलते हैं कि take it on the chin वाली बात होती है. चलो, I think this is posterior tibial artery. That was the position I think has been discussed multiple times. If it is neutrophils, then it's never an issue. But then, you know, as far as that attitude is concerned कि अभी रहने दो, तो यार वो तो हो गया ना कि आंख बंद कर ली है, बिल्ली आ रही है, right? वो that normally ऐसे सिखाते हैं ना कि the cat is there, the pigeon is closing his eyes. It's not like that, man. When you analyze, you tend to know where are you right, where are you wrong. It doesn't give you a depression. That's how you handle your subsequent challenges in life also. Okay, moving to the next one. When it was miliary TB, that's a totally separate MCQ. The one that I'm discussing before you at the moment is a different one. In this particular question, patient has taken treatment for tuberculosis. And then there is recurrence of, sir, ये miliary TB नहीं था यार. This was not miliary tuberculosis. ये बताओ, ये ऐसी कोई ऑप्शन थी क्या? पॉसिवैस्कुलर टीबी, मल्टीवैस्कुलर टीबी? Any option like multivascular TB or possivascular? Okay, options were not so complicated. ठीक है, got it, ठीक है, got it. So फिर एक simple सा question था, that was on miliary tuberculosis. That I got it. I mean, this is not bilateral infiltrates, वो seed वाला appearance था, so that would make it miliary tuberculosis. Got it. नहीं भाई, हम नहीं कंफ्यूज होते, हम वर्कआउट कर लेते हैं डेटा को. ठीक है, हम रेट्रोस्पेक्टिव एनालिसिस कर रहे हैं, पोस्टमार्टम कर रहे हैं पेपर का, तो इट्स नॉट कंफ्यूज होने वाली कोई बात नहीं है. आई एम कमिंग टू दैट आगे वाला कॉम्बिनेशन वाला ना. आई थिंक इट वाज टू कॉम्बिनेशंस डिस्क्राइब्ड इन एन एक्सरे व्हिच आर डिस्क्राइब हियर. ओके, हिस्ट्री ऑफ इरेगुलर एयर प्रीसेंट. ओके, that would be recurrence of tuberculosis, man. This would be recurrence of pulmonary tuberculosis. There is a cavity, man. There would be a cavity developing in the right hand side. That is what I'm trying to say. No, the question that is present here, if this was given, then it's not biliary tuberculosis. There's a cavity that is developing. That would be a recurrence of tuberculosis in case it was present. If not, then okay, not a problem. If it was only biliary tuberculosis, तो कोई दिक्कत नहीं है. चलो नेक्स्ट बात करते हैं. Okay, mass था middle lobe में and bronchogenic cyst was there. Okay. That is for recurrence of tuberculosis anyway. Okay, relative bradycardia, pneumonic TBR होता है, typhoid, brucella, or then can be relapsing fever. There are three questions which are responsible for that. This I think was there. Faggot sign शायद नहीं लिखा था. Relative bradycardia was there, but then we can work out the question. Yeah, I got it. वो एक अलग से cavity as per Diloma की. That is okay. I got the point. I got that point. I mean, I have already understood that question of as per Diloma cavity. Not a problem with that. We are sorted for this one. Currently at the discussion, that would be relative bradycardia. क्वेश्चन नहीं था, ये बताना यार. रिलेटिव ब्राडिकार्डिया नहीं था ऑप्शन में. Okay, fine, fine, fine. Moving to the next one, we have a type 2. भाई बीच में कई लोग कह रहे था तो चलो कोई बात नहीं, मैं मान लेता हूँ आपकी बात नहीं होगा रिलेटिव ब्राडिकार्डिया. There was a question with respect to type 2 diabetes mellitus, and a patient is developing a hypoglycemia and then is sustaining a fall, and you can see the bleed. Don't comment about the bleed at the moment, but my point is that was there information for a question regarding diabetes mellitus falling and then ending up with a head injury? That is the first thing there. Okay. Okay, question था but options पे दिक्कत है. विटामिन के FFP with न्यूरो कंसल्टेशन. तो यार ये तो खैर नहीं होगा, विटामिन के FFP या न्यूरोलॉजिकल कंसल्टेशन. रनिंग वाटर वाला अगला क्वेश्चन अभी दिखाता हूँ. रनिंग वाटर वाला, रनिंग वाटर से जो क्लॉट वॉश ऑफ नहीं हो रहा है, यार मिक्स कर रहे हो. जो क्लॉट नहीं वॉश ऑफ हो रहा है वो सबरेक्नोइड हेमरेज होता है. There's a bleeding and then it is not getting washed off. That running water से clean नहीं हो रहा. That was a forensic medicine question. I'll show that question to you also. And the clot is not getting washed off. That is subarachnoid hemorrhage. So that's a totally different one. And if there is a subdural hemorrhage present, then we'll go for a craniotomy. I had it in my Instagram, guys. 2-3 guys commented either it's a craniotomy or it's gonna be like a neurosurgery consult that we will have to evaluate for this one. Like that's a subdural hemorrhage. If it's gonna be this big a bleed, we will have to go ahead and manage this chap with performing a craniotomy. Okay. The next one talks about a diabetic patient, and he is doing a strenuous workout. He is developing prostration, तो hypoglycemia हो गया. Let me know insulin option में था या नहीं था. मैनिटॉल नहीं देते यार इसमें, मैनिटॉल नहीं देते. या आंसर इज subarachnoid hemorrhage. That is what I mentioned. वायरल स्टफ, इसमें मुझे थोड़ा क्वेश्चन की लैंग्वेज चैट में कमेंट करना आपका ना, कि जो आपने स्ट्रोक का प्रेजेंटेशन पूछा उसमें जस्ट लेट मी नो द हाउ द स्ट्रोक वाज गिवन. यार आंसर तो मुझे पता है. मैं व्हाट आई एम ट्राइंग टू आस्क इज कि इंसुलिन ऑप्शन में था या नहीं था, बस ठीक है. अगर इंसुलिन नहीं है तो फिर कोई चक्कर नहीं है. देन द आंसर विल बिकम ग्लिपिजाइड और विल ग्लिमेपराइड बिकॉज सल्फोनाइलुरियाज आर बाउंड टू कॉज डेवलपमेंट ऑफ हाइपोग्लाइसीमिया. Okay, Prakash Vishnoy says transient ischemic attack question, and they answered asked complications. Prakash, can you just enumerate on the same regarding the complications of transient ischemic attack that was present? ठीक है, got it. Fine, we are sorted for this one. And then it's about HIV पे तो I think they put up 3 questions there. HIV with Kaposi sarcoma, then with cerebral toxoplasmosis, and then was this one where the CD4 count of the patient was less and the chest x-ray was shown, like the one that is currently on the screen before you, and it says select the right combination for this case. Okay, lumbar puncture was done and they asked for long-term complication. Transient ischemic attack. Do let me know more about it, Pankaj. I am waiting for you. Considering that there is a low CD4 count given in a question, that is one. In any HIV positive patient, we will have to think of limited possibilities, and one of the possibilities to be considered would be presence of pneumocystis jirovecii infection. There are bilateral infiltrates in the chest X-ray as well, and that would make it easier for us to identify. So the correct answer for this one would be pneumocystis jirovecii. Micro slide was there also. Okay. Gomorimethame वाला होगा, समझ गया मैं. That gomorimethame information would be given. Okay. Got it. Moving to the next one, we have this patient who's having, I think ये forensic वाला है ना, कि water से आप नहीं, okay, this is not that forensic वाला. Okay, fine. A 30-year-old man comes to the emergency room with a road traffic accident. You have done a stabilization, but still उसका sensorium deteriorate कर रहा है. And then he is mentioned about vitals of the patient. And yeah, got it, Audie. That question on pneumocystis jirovecii is sorted. Let's look at this one. This is the last slide that I have as far as today is concerned. Even if there is no CD4 count, the slide gomurimythamine will make it more than sufficient for you to solve. Okay, guys, we are having a guy with a RTA, no CT scan given, and then he's talking about. Okay, fine, I'll evaluate that. फाइन ये एक बार देख लेना यार. SDH SAH और ऑप्शंस. फाइन फाइन. ठीक है, तो क्लॉट कैनॉट बी वॉश्ड ऑफ वाला जो क्वेश्चन था, दैट वाज रिलेटेड टू द पॉसिबिलिटी ऑफ सब रिकरेंट हैमरेज as a question. Okay, not an issue, guys. Not an issue. I think we are done for today's discussion. I thank you for the all the inputs that you guys have provided, and especially a couple of inputs were there which you could have been mixing, and that is perfectly normal. I mean, it happens with all of us that we tend to mix up a couple of aspects. But I think we had like 34 odd slides that I discussed. Maybe 3 to 4 were not there, but still 30 is what I think I've tried to discuss here before you. So thank you so much, guys, for joining in, and it's been great teaching you guys and interacting also. And in case you have any more inputs, you're most welcome to drop me an email at marvamedicine@gmail.com. And it would be great in case you can just fill in those options, in case I missed maybe some part of the chat because it was going up very fast. So in case I could not reply to you, just and you think that that point was important, just drop me a mail, maybe a one-liner, two-liner, three-liner, whatever you feel in, and I would really be happy to hear from you guys. Craniotomy would be done for subdural hemorrhage, but I'll yes. Yeah, I SS that I've said already. That would be subrecurrent hemorrhage only. पेंस्टोस प्रोटीन कहना थोड़ा सा हो जाता है इस तरीके से. अनसरी ब्रेन डिवाइस, कौन सा डिवाइस था यार? DBS, deep brain stimulation. This one would be EDS, doctor. This would be extradural hemorrhage because the patient is not, all other options are going in favor of hemorrhagic shock. No, so if you're ruling out hemorrhagic, it would be extradural hemorrhage. CD4 count for Kaposi would be 200, doctor. Yes, Audi, that's perfectly right. The water is not going to wash off the clot. HSP is IgA encephalitis. Okay, guys, what we'll do is we'll do more brainstorming. We have had some good inputs, so it's gonna take a while for us to basically recollect everything and come up with a form that's gonna be most accurate and closest to the actual recall. So this was more of like a verbal autopsy for me that I was trying to do, but anyway, was brain so peritoneum को connect जो है, that is VP shunting, man. That is VP shunting. If there's a device, no, that catheter is gonna be VP shunting. So there was an image for VP shunting. Got it. That's a good input. I took a snapshot of that also. So fine, guys. Thank you so much, and bye bye. See you guys.